it's my pleasure to introduce Mr. Alan Kirk, who is a thoracic surgeon. He's heavily committed with medical education, involved in national selection. So, and I'm looking forward to hearing about his insights on why he became a thoracic surgeon and hopefully inspire you into the world of thoracic surgeries, so much more than just lungs. Over to you, Alan.
Farah, thank you very much, and thank you very much to the organising committee for the honour and privilege of and pleasure of presenting today. I'm old enough to do what I want when someone gives me a title. I was given the title of thoracic surgery, and I elected not to go down a technical route, although there will be some technical things in it. I just wanted to share my journey over my experience and how things have got here today. So next slide, please. It wasn't so much why I became a surgeon, because of I chose it for a particular reason. Next slide. And in fact, the whole title should really be how I became a thoracic surgeon, because it was, in fact, almost by accident. So let's go back many years, not that far, but when I grew up as a little boy, I was a very pious little individual. I went to Sunday school and Bible class, and living in the central belt of Scotland, David Livingstone was one of my schoolboy heroes about being a medical missionary. He was grown up and born and worked, for a while 15 miles away from where I used to live, and he really was an inspiration in early life, as was, next slide please, Albert Schweitzer. Now both of these were incredible men. They were medical missionaries, and from the age of 5 I wanted to be a medical missionary. I grew up in an era when the guidance was, Kirk, you're a clever boy, you'll be doing medicine, won't you? Smith, you're not quite so clever, you can go do dentistry. That was the level of career guidance I got. And next slide, please. When I successfully got into medical school with absolutely no interview or anything else beyond application and personal statement, I pitched up in October 1974 outside the zoology building in the medical school. Well, it wasn't a medical school, it was a medical faculty in Glasgow. And as I looked around in the car park as we tried to get in that morning, I imagined that in 5 years' time I would either be a GP, which I knew what a GP was, or a consultant surgeon with a beard and a Bentley. Next slide, thanks. Because my media influences, with no career guidance, being the first person in my family to go to university, I thought that's what a consultant surgeon was if you weren't a GP. And next slide. There was his lovely Bentley. Now, over the years, I had no idea about the concept of postgraduate medical training or subspecialties, but obviously my career took me a different direction. So I got the beard, as you can see, next slide. And I certainly did not get a Bentley, but I had a lovely Jaguar at one stage, and I loved that to bits. And unfortunately, it had to go. Next slide, thanks. And that went away. That was replaced. The wife was replaced by a Mini. She got my car and 2 dogs. And I say this really tongue-in-cheek. But the next slide, please. I want to punctuate my talk with a little bit of the lessons that I have learned. And part of the reason for my marital breakup and loss of my beloved Jaguar was my attitude to a poor work-life balance. Vipin Zamvar has already talked this morning about, yes, you can have a fruitful family life in this day and age, but you do have to work at it. Cardiothoracic surgery is hard, and perhaps it isn't really like so much of a balance, but more of a pendulum. Sometimes you'll be a mother, sometimes you'll be a cardiac surgeon, sometimes you'll be a dad and walking the dogs, sometimes you'll be a lung transplant surgeon. So in trying to balance things out, I had no work-life balance early on in my career as a young consultant, as a trainee. I now have taken up sailing later in life, and instead of chess, which I really don't understand, I play bridge at a reasonable level. Next slide, thanks. And again. So let's get back to me. So once I got into medical school and out the other end, I clearly, even then I said earlier on about being a consultant surgeon or a GP, surgery was always a thing for me for reasons I didn't fully understand. I had a fantastic medical undergraduate experience. I wanted to be everything. I even wanted to be a psychiatrist at one stage because of the excellent teaching we got. But surgery it was to be. And after my house jobs, my 2 house jobs, I had a fantastic orthopaedic SHO post, which gave me the groundings in for preparation for the primary FRCS, and then ultimately to the next year onto a rotation of 4 3-month specialties of cardiothoracic surgery, neurosurgery, peds, and a shot at general. And that was a fantastic, always a developing core training post, because that allowed me to pick what I wanted, and cardiothoracic was the one I wanted to do. Shortly after that, I got into the very prestigious West of Scotland General Surgical Training Scheme, which was 2 years in general surgery, 1 in the teaching hospital, 1 in the district general, and then 6 months of vascular, which I thought was an appropriate specialty for a cardiothoracic surgeon, and 6 months cardiothoracic. And then got a numbered job for 3 years, and then went down to Newcastle, had a fantastic time at the Freeman, both at the university and at the Freeman, and ultimately got, after a fellowship over in St. Louis, Missouri, more of which later, became senior registrar in one of the best thoracic training centres outside of Toronto at that time. That's Frenchy Hospital in Bristol. And then I came, not back to Scotland, I came to Scotland in 1994 because the job of thoracocardiac surgeon was advertised, and it was just right for me, and it was just right for my unit. Next slide, thanks. So a second lesson, apart from getting your work-life balance right, is what I've said in my little, my mini job description there, is we are in a society in the UK of, obviously UK, Scotland, Ireland, Wales and England. The society is the Society for Cardiothoracic Surgery of Great Britain and Ireland, but I think sometimes you do have to move around a bit. Next slide. And we do live in a global environment, a global economy, and cardiothoracic surgery is a global specialty. And many of my close friends and confidants are not in the corridor next door to me, they're in Pisa or Turin or North America somewhere. So it really is the ability to become a top-class cardiac or thoracic surgeon or any other medical specialist, you have to look globally. Next slide, thanks. So a little bit more of my journey. When I was appointed in 1994, lung surgery, chest surgery, 95% of lung operations were performed by mixed practice, highly qualified cardiothoracic surgeons doing both cardiac surgery and thoracic surgery, sometimes in the same list, sometimes in different days. There were predominantly lung cancer resections, and tongue-in-cheek, it would quite often in these days be cabbage times 2 in the morning, AVR times 1 in the afternoon, and then bugger off and let the registrar do the pneumonectomy or the lobectomy at 3, 4 in the afternoon. We also had our fair share of empyemas, pus in the chest, collapsed lungs, pneumothorax, and malignant pleural effusions. And in general terms, although I loved the thoracic experience in Frenchy and Glasgow at that time, it really was a Cinderella specialty, with outside of London probably very little private practice, if that motivated anyone at the time. Industry support was non-existent, and there was no sponsorship to go to the American or European meetings. That was 20 odd years ago. Next slide, thanks. However, something changed thoracic surgery in Scotland and perhaps UK, and certainly in me, when we moved to the Golden Jubilee National Hospital. 3 first-class units, the Western Infirmary in Glasgow, the Royal Infirmary in Glasgow, and Hairmars Hospital in East Kilbride, moved to this relatively new build to the West of Scotland Heart and Lung Centre in 2008. Next slide, thanks. And that economy of scale allowed us to change what we did and to had an impact on my career. And cardiac surgery, after 10 years of doing it, was beginning to think on a modern job plan of 2 operating sessions on average, so 2 operating days a week, began to think I can't really do everything, or I can't do everything. I certainly couldn't do everything that well. I began to doubt myself, can I actually do anything? There were increased risks. The things I cut my teeth on as a young consultant and as a registrar of, fit, healthy 40-year-old man with a tight proximal LED stenosis for a single graft. These were registrar operations in those days. Whereas with aging population, cardiologists quite rightly doing things as good or better percutaneously. The patients we were beginning to get were older, riskier, more comorbidities. And at that time, as I'm sure Mr. Kendall, as president of the society, will talk about, is there was in cardiothoracic surgery in particular increased public and journalistic accountability and scrutiny. And cardiac surgery for me in the mid-2000s was beginning not to be a good place. And I concentrated therefore on thoracic surgery, surgery of the chest. Next question, next slide, thanks. So in 2018, you know, right up to date, things have swung completely around the other way. 95% in UK, perhaps not England, where it should be 100%. 95% of lung and thoracic operations are done by appropriately trained general thoracic surgeons with the support of all their team round about them. Lung cancer resections 20 years ago were predominantly at big open operations that I'll show you in a minute, but now we've gone on to video assisted, keyhole surgery, and increasingly in many units, including ours, robotic assisted surgery. The lung resection rates 20 years ago, 10% of the 4,600 cases of lung cancer each year in Scotland got an operation, 90% didn't, whereas now in some areas in the west of Scotland, it's pushing 30% with an average of about 20-25. We continue and probably get increased numbers of the pleural disease of empyema and collapsed lung, etc. And yes, it is still a Cinderella specialty, but only in the sense that Cinderella has now gone to the ball. Private practice has never really motivated me. With low waiting lists in Scotland, private practice in Scotland is not a big feature for many of us. Excuse me. Industry partnerships have flourished over the past 20 years. Industry are now designing special instruments for us. They're developing robotic platforms and sponsorship to help us not go to the meetings in North America, but sponsorship to allow us clinical immersion courses in other units, and collaboration and peer support is absolutely fantastic. Next slide, thanks. And my current operating plan, or not operating plan, my job plan is in Monday I spend all day in theatre. I paradoxically do a transplant clinic in the morning and a thoracic outpatient clinic in the afternoon. Wednesday I operate all day, and that's, I don't know about my English colleagues, but we push really much for 2 operating days a week. I do 2 separate lung cancer MDTs on a Thursday, and on Friday it's a bit of a mishmash. I do a lot of teaching and audit, and we do have developing specialty MDTs with sarcoma, emphysema, mesothelioma that occupy our time on a Friday. That's kind of what I do during the week. Next slide, thanks. So why did I go in for thoracic surgery? This is, apologies if any of you have seen some of these things before. This is the best birthday present I've ever had in my life. My wife gave me a bit of paper. I opened up my birthday and I was really excited because I thought it was a cookery course with Tony Singh in his restaurant or his cookery school. It wasn't. It was him coming to the house, helping us cook a banquet, and sat and eat it. And that was absolutely fantastic. And the whole point of putting this in, apart from the fact I enjoyed it, and his teaching methods were almost exactly the same as the teaching methods I use for my trainees. Next question. And next slide, was that variety really is the spice of life. And one of the great attractions of thoracic surgery to me was the heterogeneity, the different things we can do within it. Next slide, thanks. So thoracic surgery, how do you decide if you got to meet someone at a cocktail party and say, hi, I'm a brain surgeon? They kind of know what you do. And you say, hi, I'm a plastic surgeon. They kind of know what you do as well. Thoracic surgery is a bit more difficult to prove what we do. Next slide, thanks. But my definition for medical students is really that thoracic surgery is an amalgam of operations that can operate any structure within the chest. We do 1,400 operations a year. 500 of them or thereabouts are for lung cancer, which is our primary raison d'etre, but we do all these other things in lower numbers. Collapsed lungs, probably 100, 150 a year. Trauma, 20, 25 cases a year. surgery for COPD, 40 to 50 a year, mesothelioma, a few. So you need to know the context, but it really is a fantastic variety of things that keeps everyone's interest going, which we can indulge ourselves in a large unit, which we couldn't previously do in a small unit. Next slide, thanks. So the third lesson in terms of developing what we do and what I have done over my years is I found this book. This is a kind of one of these business guru books that I found lying around my wife's bookcase, and it was From Good to Great. And the kind of message of this was, no one can do everything. Concentrate in business terms of what you can do well. Next slide. Which is kind of what we did in thoracic in the west of Scotland over the past 10 years. Our default position for lung surgery was on the left. You can see a big thoracotomy wound. You can see the open part of it there where the lungs popping out, the dirty big prehistoric retractor pulling the ribs apart. And what you can see there is the way that we used to do lung surgery 12, 15 years ago. Next slide. But by ditching some of the other things I used to do, like the esophagus that Frenchie trained me very well to do, this allowed us to develop, in specialty terms, different ways of doing things. We were laggards at doing VATS lobectomy. This is my very first proctored VATS lobectomy case in about 2012, and it allows us to get better results, or as good results, with better recovery for patients. And VATS, Doug West, if he's on the call, will correct me, but I think 60 to 70% of all lung operations are now done by keyhole means in UK. We are about the 75 to 80% mark. Next slide. And you can see that a graph that I actually quite like, that it's a self-fulfilling thing because it's binary, but you can see the blue line is the number of thoracotomies we used to do, which has greatly fallen, and at the same time the number of VATS operations have gone up and up and up. Next slide, thanks. We've been in the very fortunate position to be allowed to use and have a robot used exclusively for thoracic use at Golden Jubilee. This is one of our early ones. Next one. And that is our robotic team. We're talking little bits about opportunities. The person at the back there is Jen. It's worth making a political point that I think 50% of the cardiothoracic trainees at the moment are female, 50% being male. But we are very underrepresented in terms of female consultants. From what I see happening at the moment, that will change in the future, and Jen and her colleagues will be the future. But robotics has taken us in thoracic surgery to a different level. And just before we lose sight of things, I've flippantly said at presentations before that the most important person in the team is not there because it's me sitting at the console. And a little nurse put her hand up and said, "Excuse me, Mr. Kirk, is the most important person not the patient?" And that was a very humbling experience as well, which is absolutely true. Patient is the focus of what we do all the time. Next question, thanks. Next slide. Lesson 4 is, and I think both people that I've already heard this morning have talked about the value of role models. Ken Davidson was a first-class cardiothoracic surgeon in his day, Edinburgh graduate, worked his consultant job in Glasgow. He inspired me to do cardiothoracic surgery. He inspired me to continue and supported me throughout. John Walwork on the right there was his senior registrar in the late 70s in Glasgow, getting his CBE there, and he has been a constant source of support over the years. And Joel Cooper, who I worked with, the father of lung transplant in Toronto, and moved to St. Louis, where he developed the techniques that we still use of lung volume reduction and end-stage emphysema. The value of a role model is immense. Next slide, thanks. So things do change, I think. The specialty I went into in 1994 as a consultant and 85 as a registrar is not the specialty that I now am part of. Next slide, thanks. So in summary of all these little points, in terms of whatever specialty you get into, and we are hopefully this whole motivation day today for you is to show how great a career cardiac and thoracic surgery can be and is, but do get your work-life balance right for you in whatever you do. Do remember, and I think it makes you a better person if you have to move around, and do remember that you can't do everything, and don't forget your role models and your proctors and your mentors, and don't ever forget that you one day, even now, will be a role model to someone else. Next slide, thanks. And the last thing there is embrace change and enjoy yourself. I've had a fantastic career. I hope I've given a lot back to that, but get on with it. Next slide, thanks. Because enjoy yourself, but it does not seem 30 odd years since I stood outside that zoology building as a medical student. Thank you very much for your attention.
Well, Alan, thank you so much for such an engaging talk. I've got a few questions that come in the Q&A, if that's okay. I was going to bridge to you.
Of course.
Yeah, so you talked about being a top-class surgeon and about looking global, and you mentioned your own influences, which included Joel Cooper, that came from the States. And one of the students just wants to know, would you recommend going to the United States to do a fellowship at any stage?
Right, I think, and if there is a Q&A for Simon Kendall later on, I think his wisdom would be valued as well. There used to be, you're probably too young, Karen, to remember, but in my day, you had a qualification called BTA, Been to America. I think a fellowship to go somewhere else to get added expertise, you can still do within the UK environment, but I think experiencing other healthcare environments as well is fantastic. Keith talked about, I think, India, Pakistan, South Africa. It doesn't have to be America. And in actual fact, there's a lot of places in UK. Keith looks after South Africans and Australasians that come here for fellowships. We hope to attract robotic fellowships here. But for UK trainees, I think it is it's not essential, but it is well worthwhile experiencing something else. It doesn't have to be America.
Okay, super. And so one question was just, is it possible to still be a cardiothoracic surgeon? Just through your talk, obviously that's your own experience, but is that going to be the norm moving forward? There
are, as some of the consultants around this table will know, there are some guerrilla thoracic surgeons that want to completely divorce from cardiac surgery. The desire to have a thoracic surgery as a separate specialty was to deliver better care, for the patients. It was never a criticism of the qualities of the mixed practice surgeons that Simon Kendall was until very recently. I do think it is better. Sorry, I forgot what your question was, Karen.
Just will it be possible for? Yes, sorry.
Oh, sorry, possible. Yes. So in England, the commissioners and society with a small s and everything else have said no. Western Europe, no. North America, USA, Canada, no. Australasia, they're beginning to change, but yes. I think some of the smaller states in Malaysia and Singapore, perhaps. Geographically remote areas in such awful places as Wales and Scotland and Ireland, by necessity because of the rural diversity there, Keith Buchan is a fantastic first-class cardiothoracic, but I don't think the UK platform will be able to support that. If you want to be a cardiothoracic surgeon in the future, probably have to go to another country.
What's your thoughts on being a thoracic surgeon and a lung transplant surgeon, Alan?
I said when I was talking about what I did during the week, I was well trained in both cardiac and pulmonary transplantation in Newcastle and in St. Louis. It is a disappointment to me that my high quality cardiac surgical unit in my hospital has never, for political reasons, embraced lungs. I think it's part and parcel in many units of what we should do. That is why I've continued to do the clinic until recently. I did the retrieval. That shaved many years off my life being a retrieval surgeon, but no, I want to be that. The colleagues in Dublin do that, Manchester as well. Yeah, I think, and I think you might do as well. Yeah.
Yeah.
You're a cardiac transplanter.
Yeah, I am, but I do see the value in a thoracic surgeon doing lung transplants. I do support that.
Yeah, because you can manage your own airway bloody complications. That's what you can do.
All right. Have you been speaking to my colleagues by any chance, Alan? I feel like that's a bit of a personal thing. That's right. I'm not allowed to do bronchoscopy.
Not at all.
I would argue that I'm more than capable, but yes, that's true. I'm not allowed to. I'm just going to share screen just at this point. So we've had some really, really great Twitter responses and on Facebook, just for the students that are listening. There's been some really fantastic talks. Just to highlight at the bottom of the screen, these are our Facebook, Twitter, and how you can get in touch with us on email. Please continue to send in your questions. But if you've got anything you want that you haven't thought of at the minute that you want to speak to the speakers about afterwards, you can get in touch with us via that. So that's great. But thanks, Alan. That was a really great talk. I'll hand back to Farah.
Thank you, Karen. And just for some of our younger colleagues listening, the training is combined. So you will apply for a cardiothoracic training post, and so you have a sort of common beginning of your training, and then usually you will decide which sort of subspecialty you want to focus on. So thanks very much, Alan, for not just a talk on thoracic surgery, but a few life lessons as well. So